Okay, let's dive right in. We are going to deconstruct hypothyroidism, breaking it down into a framework that you can take straight to your exams and, more importantly, into your clinical practice. We're going to cover the what, the why, and the nursing actions you absolutely need to know. So to get us started, let's think through a patient puzzle. This is based on a real case study. Just imagine, this patient walks into your clinic. She's anxious, her voice is kind of hoarse, and she's got this whole mix of symptoms. You're the nurse. Your assessment starts the second you lay eyes on her. So what single, underlying cause could possibly connect all these dots? To solve that puzzle, we've got to look under the hood at the body's master regulator of metabolism, the thyroid gland. You can really think of it as the body's engine, setting the pace for literally everything. Okay, if you remember just one thing from this entire explainer, make it this. This concept right here, low and slow, is the key that unlocks almost every single sign, symptom, and intervention we are about to cover. This is your golden rule for the NCLEX. So how does the body even regulate this? Well, it's through something called the HPT axis. Think of it like a smart thermostat in your house. The hypothalamus, that's like you feeling cold. It sends a signal to the pituitary, which is the thermostat on the wall. The pituitary then releases TSH to tell the furnace, your thyroid, to kick on and produce heat, or in this case, T3 and T4 hormones. Once the room is warm enough, the thermostat signals back to shut the system off. A problem anywhere in that chain can cause hypothyroidism. And what's the fuel for this furnace? What does the thyroid gland actually use to make these hormones? It's iodine. For your exams, you have got to remember that a lack of iodine is a huge cause of hypothyroidism around the world. It's really that simple. No iodine, no T3 and T4. All right, let's bring this all back to our patient. We're going to connect these low and slow principles to the actual real-life signs that we're seeing at the bedside. Now, what's really interesting here is how all these low and slow symptoms are organized. See, a patient might just say they feel tired, or they're constipated, or that their skin is dry. By themselves, those complaints are kind of vague, right? But when you, as the nurse, start clustering them together, the slow heart rate, the fact they're always cold, the weight gain, that's when a clear clinical picture of hypothyroidism starts to pop right out. So our nursing assessment is pointing strongly in one direction. Our gut is telling us something's up, but we can't diagnose based on symptoms alone. We need definitive proof, and that comes from the lab. First up, we look at the TSH, the thyroid stimulating hormone. In primary hypothyroidism, this number is going to be high, usually over 5. And why is that? It's because the pituitary is literally shouting at a thyroid that isn't listening. It just keeps screaming, make more hormone, driving that TSH level way up. For the NCLEX, a silly way to remember that upper limit of 5, think TSH, like tush, 5 fingers. You get the idea. It works. The second piece of our diagnostic puzzle is the T4 level itself, and that's going to be low, less than 4.6. This confirms that the thyroid gland just isn't making what it's supposed to. So you have this classic combination, a high TSH and a low T4. That points the finger directly at a problem with the thyroid gland itself. And this right here, this just shows you the real-world impact. This was our patient's actual EKG from her first visit. Just look at that rate, a really significant sinus bradycardia at only 44 beats per minute. That isn't just a number on a chart. That is a heart that is physically struggling because of the slow effect of severe untreated hypothyroidism. Okay, so we've cracked the case, we have our diagnosis, now what? What's the nurse's priority? It's all about intervention and, of course, patient education. The great thing is that the treatment is beautifully logical. If the body is missing a hormone, what do? We replace it. The go-to medication for this is Levothyroxine, brand name Synthroid, which is just a synthetic version of that T4 hormone the body's not making. And this slide right here, this is NCLEX Gold. You have to know these teaching points. First, this is lifelong therapy. You don't just stop taking it. Second, it has to be taken first thing in the morning on a totally empty stomach with only a full glass of water. And you have to wait at least 30 to 60 minutes before you even think about that morning coffee. Third, other things like antacids, calcium, or iron supplements will mess with absorption, so they need to be spaced out by at least 4 hours. And finally, the patient has to know the signs of getting too much hormone, which basically looks like hyperthyroidism, things like chest pain or a racing heart. And just look at the power of that simple intervention. On the left, her heart rate is crawling at 44. Then, after 20 months of taking her levothyroxine correctly, on the right, her heart rate is up to a much safer 58. I mean, that is a visual testament to effective treatment. And it wasn't just her heart rate. Look at this data. Her crazy high cholesterol and LDL levels, they started coming down. Her anemia, which we can see from that low hemoglobin, it completely resolved. And her liver enzymes, the AST, they totally normalized. This is the proof that her facial droop, her depression, all these weird lab values, they were all tied back to one single root cause. Now, while most cases are managed just fine at home, as a nurse, you have to be ready for the worst-case scenario. You need to know the life-threatening red alerts. And this is it, Myxedema Coma. It's the ultimate low and slow state where the body is literally just shutting down. You're going to see severe hypothermia, respiratory failure, and a heart rate and blood pressure that are just bottoming out. Your number one nursing priority is to recognize this immediately and get ready for IV thyroid hormone and some really aggressive supportive care. We also have to think about the other end of life. Congenital hypothyroidism is the whole reason every single newborn in the US gets that little heel prick screening test right after birth. If this gets missed, the lack of thyroid hormone leads to permanent, irreversible intellectual disability. The brain absolutely needs T4 to develop properly. The treatment is simple and effective, lifelong hormone replacement, and it has to start right away. So what's the big takeaway here? Let's go back to our patient. After she got treatment, this is what she reported. I mean, this quote just says it all, doesn't it? We're not just fixing lab values or an EKG. The power of a sharp nursing assessment and effective treatment is that we can completely give someone back their quality of life. This case is such a profound reminder for all of us. This patient suffered for 2 whole decades because her condition was forgotten. So the question I want to leave you with is this. What subtle low and slow signs, the fatigue, the dry skin, the constipation, might you be the first to spot, connecting those dots and solving the clinical puzzle before another 20 years can go by?